So hi everyone, very good afternoon to all of you. So we are here with the obs and gynae recall. There are questions that have collected and hopefully we have the most as well correctly recalled. But yes, we are here and you can let me know anything in the chat box that you feel like contributing for the recall questions, right? Everyone ready? Okay, so this is the first question, that the recombinant HPV vaccine has which antigen, right? So which antigen do we use? And this is actually covered in PYT also, and I recently covered it up as an MCQ revision series in the Telegram channel as well, right? So the answer is going to be L1, right? So it is the L1 capsid protein of the virus. Whether it is a quadrivalent vaccine or a nonavalent vaccine, right? Whatever, what we make is VLPs, right? So VLPs are made from L1 capsid protein of the virus. That's right. So that is going to be the answer here. Okay, it's not E1, E2 and it's not E6, E7. E6, E7 is for malignant transformation and E1, E2 are for viral replication, right? So when it is the vaccine, it is L1 capsid protein. Let's quickly look at the second question. So this was a question which simply said virilizing ovarian tumor, right? Now please remember, as far as Brenner's is concerned, it does not produce any of the sex hormones, right? So not estrogen, not androgens. Similarly, carcinoid also doesn't really produce. Thecomas, I think, was a confuser for you all. So thecoma is primarily a estrogen producing tumor. Okay, it is primarily a estrogen producing tumor. So when we talk about a virilizing ovarian tumor, it is actually arhenoblastoma, right? So it is arhenoblastoma. Okay, let's look at this question. So this question was, what is the reason for increased blood volume at term in pregnancy? Okay, and the options were A, increased fluid retention, action of aldosterone and estrogen, right? Then action of aldosterone and ADH, and then there was an option which said both A and B. Now this is something that we've already always talk in the class also, that when we talk about most of the physiological changes, they are because of progesterone. But I especially tell in my class that when we talk about estrogen, there are three physiological changes that are primarily mediated by estrogen, one of which is fluid retention, right? So pregnancy mein there is a retention of as much as 6 liters of fluid. Okay, so estrogen contributes, and it contributes by upregulation of the RAS. So there is upregulation of aldosterone and renin, and there is fluid retention by the kidneys. Both salt and water retention is there, but water retention is much more than the salt. Yes, so the answer is going to be D. Both A and B are correct. Okay, which is there will be increased fluid retention as well as action of aldosterone and estrogen. Let's move on to the next one. So this was a question which said management of uterine inversion with placenta still attached to it, and the next step was asked, right? So they have asked you the next step. Again, this is exactly how we do it in class as well. So I've just brought down the images from the class. So we specially give you a case scenario like this in the class if you've attended, that if the uterus inverts and it's lying outside and the placenta is still attached to it, what are you going to do? I always talk about, are you going to give oxytocin? Are you going to remove the placenta? Are you going to shift her to OT? Or are you going to do a manual repositioning first? So always you have to begin with manual repositioning. Shifting to OT is not what you do right now, right? You have to try manual repositioning, and only when you have finished or you've done major part of the repositioning, you start oxytocin, and then once it is repositioned, then you will remove the placenta, right? So here the answer is going to be reposition of the uterus without removing the placenta. Okay, one of the options said shift to OT and insert the uterus back under GA. That's what the complete option was. If you have any other recall, you can let me know, but that's not correct. The next step is not that. The next step is that you have to try manual repositioning and the placenta has to be still attached. That is the last thing you will do, the removal of the placenta. Okay. Okay. So then there was another question, which is a woman is 3 centimeters dilated, 70% effaced on PV exam, and there is a bag of worms that can be filled, right? Which means the membranes are still intact, and through the membranes, okay, through the membranes, you can feel the bag of worms. What is that? That is nothing but the umbilical cord, right? So this is not a outright cord prolapse. It's actually a cord presentation where the cord has come below the presenting part, but the membranes are still intact, right? And this itself again is an emergency situation, just like cord prolapse, right? So what you have to do is take the patient up for emergency cesarean section. Okay, take the patient up for an emergency cesarean section. We are not going to give oxytocin, and we are definitely not going to do rupture of membranes, because that will cause a overt cord prolapse, right? So the answer would be simply take her up or shift her up for an emergency cesarean. Okay. Let's look at the next question. Here I don't have the fourth option. So if you can give me the fourth option for the recall, that will be great. So this is a patient who has been taking DMPA regularly, but this time she has come 14 days late with respect to her due date for DMPA. Right? What is the advice? So again, something that if you go on to the contraceptive topic that we have covered in the class, right? For DMPA, the WHO says the grace period is 4 weeks and CDC says the grace period is 2 weeks, which means in this grace period, you don't have to do anything. No UPT to be done, no backup method to be used. You can simply give her the next dose of DMPA. In the question that we have got in the exam, this is exactly what was asked, that she has come 14 days or on 14th day or 14 days late. So answer will be simply give DMPA and no backup is needed. UPT is also not needed as long as she is in the grace period. All right. So that's the answer for that one. Okay. So which of the following has risk of, I think it was risk of, not not risk, not was not there. So it is a risk of progression to borderline ovarian tumor. Now, when we talk about ovarian tumors, the risk factor is actually infertility, right? So, which we take it as nulliparity. There is no doubt that PCOS also increases the risk slightly with respect to ovarian cancers. But yes, if we have to choose out of the two and nulliparity was in the options, then we are going to mark nulliparity, right? I've always told, instead of focusing on treatment protocols and new things, it is very essential that for endometrial cancer and ovarian cancer, for INICET, you must look out for risk factors. So nulliparity and infertility are important risk factors with respect to ovarian cancer. Okay, so that is the best answer among the options given to us. Okay. Now, I don't have the correct image for this one, but it was clearly an image of Rinke's crystals, and there was a history given. Probably it was written that it helps in bringing about sexual characters or secondary sexual characters. Does anybody recall the history part? Now, the problem is normally we say Rinke's crystals are seen in certainly Leydig tumors because that is the classification of the tumors. But in this question, certainly was a separate option and Leydig tumor was a separate option. So, Rinke's crystals are very characteristic to Leydig cell tumor. So, if they are both in the separate options, the answer is Leydig cell tumor of the ovary, right? Okay. And yes, if anyone can contribute the image as well, that would be nice. We don't have the exact image. Let's look at this question. So this was a question where the G6L1A3, and what was given to us is that she has had 2 previous cesarean sections. We were asked which will not be taken as a part of the consent, right? So are you going to take consent for bladder injury? Yes. PASS. So most of the options had PASS. PASS is placenta accreta spectrum. So more these cesarean sections, the higher is the risk of PASS. So please remember, yes, there are chances of blood transfusion also. If there is PASS, there can be massive blood loss. Because it is PASS, the management itself is hysterectomy, right? So the best answer here is going to be A, chances of bowel injury, right? So chances of bowel injury nahi hai, but bladder injury definitely yes. So what is not a consent is chances of bowel injury, right? Okay. So this was, I think, a forensic MCQ primarily, and they will discuss it as well. Maybe it was a PYQ as well. So 13-year-old girl, and she was 8 weeks pregnant. Okay. Yes, exactly, Pavan. So that's what we are saying. Which one will you not explain while taking consent means which is not a part of the consent, right? And that is going to be chances of bowel injury. वो नहीं explain करना है, ठीक है? Right. So this was a 13-year-old girl who is 8 weeks. She came with amenorrhea, right, and pain, and she's 8 weeks pregnant. The UPT is positive, right? So what are you going to do? What is the next step was asked. So yes, the answer is you're supposed to register an MLC and you're supposed to inform the police. Okay. So register MLC and inform the police. Okay. Let's look at the next one. So a girl comes with history of irregular cycles, and if I have the right recall, I think the age of the girl was around 25 and even a BMI was given, right? So BMI of probably 29 was given. So this girl has history of irregular cycles. Her hirsutism score was given as 6. Testosterone levels were also given, and it was said that her mother is diabetic. Okay. So her mother is diabetic and she is on medication, right? So what should not be advised? So the question is, what should not be advised? So are you going to advise her a lifestyle modification? Definitely yes. She has a higher BMI. Are we going to inform her about the metabolic risk? Yes. So we are going to, explain her that as well, which means now we come to A and B. So the answer is based on what is not to be done. Right, so the answer is B. Combination of OCP and anti-androgen. So this is again something which is directly from your class notes. I specially teach you the algorithm on how you're supposed to initiate the drug therapy. Right, so please remember the drug of choice for irregular cycles, for PCOS, for hirsutism is OCP. So you begin lifestyle modification, you begin OCPs, but you never start anti-androgens with OCP together. You're supposed to give OCPs for a span of 6 months, and only if hirsutism does not improve, only then you will additionally add an anti-androgen to her, right? So the option is OCPs have to be given, but not a combination of OCP and anti-androgen, right? Okay, let's move on to the next one. So this was a long clinical case where your patient was 30 weeks pregnant and there was some information given. She comes to us with decreased fetal movements and maybe bleeding as well, right? On PA examination, her uterus was 34 weeks. The fetal heart rate is absent, right? You cannot hear the fetal heart rate. A high blood pressure was given. It was written that she had wet undergarments, but bleeding has stopped now, right? And this woman is also in labor. She's 6 centimeters, 50% effaced. And what is the management? So this is clearly a case of abruption. We all know that abruption is the most common complication of preeclampsia, right? And once it is abruption, I've always taught you that there is no role of conservative management. So management of tocolytics is a big no. You never give tocolytics with abruption. There are very, very occasional areas where we might give tocolysis, but otherwise no. Similarly, observation, no. It is an acute abruption and we need to do a termination of pregnancy. Now coming to the question, how will we do the termination of pregnancy? So please, again, this is again a special case scenario that I always do in my class, especially with respect to abruption. And when the patient is in labor and she has abruption, and I specially teach you the mother is stable, right? But the baby is dead. Okay, the fetus is dead, the mother is stable, and she's about to deliver. Then you have to go ahead with vaginal delivery. And the best thing about that is to do an ARM. Why? Because ARM not only helps you to confirm the diagnosis, it temporarily reduces the bleeding and it makes the woman go into faster progress of labor because of release of prostaglandins, right? So in this question, once the baby is dead, mother is stable, we are going to give her antihypertensives and do an ARM. As I said, ARM solves three purposes. I always teach like this in the class. Number one, it will reduce the temporary bleeding. Okay. And number two, it will, accelerate the process of labor, and it also helps you to confirm the diagnosis because you will see blood stained LICA, right? So the answer is antihypertensives and ARM. Okay. I think the station was another question, okay, which was with the cord presentation, right? In that question, it was 3 centimeters, vertex at -3, and I think 70% effaced, okay? Why can't it be A? Why would you do an emergency cesarean when the baby is dead? Also, especially when she is already in labor, and I hope you remember, I teach in class, in abruption, there is release of tissue thromboplastin. Do you remember? Yes, and we said this tissue thromboplastin is a potent uterine, it initiates uterine contractions. So a lot of times these women with abruption will go into quick labor or even precipitate labor. So you can actually make her deliver very quickly vaginally. All right. Also, please remember, there are chances of bleeding which are going to be more with cesarean sections as compared to vaginal delivery. So why put the mother in even more risk when the baby is dead? Okay. We would mark cesarean only if the question had fetal distress, right? Then yes, we would have quickly shifted her for cesarean to do a quick delivery. So had there been fetal distress, had there been unstable vitals of the mother, right, like hypotension, then yes, cesarean would have been a better answer. Not here, bacha. Okay. Right. So now again, it is a core, path question. So I am not going to commit an answer, but yes, since I don't even have the correct image for this one. So maybe the answer is toluidine blue, but we need to wait. Okay, yes, pap Nicolo is the stain we use for pap smear. But I think the image they showed did not have any pink color, as I got the recall which said background blue cells the or blue background tha, and there were very small blue cells. Okay. No, Divya, FHR was not heard. Okay. FHR was not heard. It was not written as 120 app. Divya, you are confusing a bag of worms or feeling of worms wala question with this question. In that question, the fetal heart rate was given normal, right? Where the woman was in labor and you could feel a bag of worms. There the FHR was given as normal FHR. In this question, FHR was given as absent FHR, bache. Okay. Yes. So because of the image, so until I have the image, I'm not going to commit, but I think the better answer is toluidine blue. We should still wait for the pathologist to come up with the right image because it was a question core on stains, right? So let's wait for this one. Now, this was a question where the lady is 65-year-old woman and she is a case of ovarian cancer. And what was given to you was CT scan findings. The CT scan showed omental caking. Do you understand what it means? And it showed ascites and it showed peritoneal metastasis, right? Which means there is extensive spread of the cancer. She is an advanced stage cancer, right? And again, something that I routinely teach in the class. So I'm just going to show you a snapshot from the class itself. Okay, so we teach you that when the patient cannot be cytoreduced optimally, which is when she has peritoneal metastasis, she has ascites, she has omental caking, which means if you operate her first, you will not be able to remove all the tumor, right? So she cannot be optimally cytoreduced. Okay, so what are you going to do? You should first give neoadjuvant chemotherapy. So 3 cycles of chemotherapy are given first. Then we will do a debulking surgery and then we will give 3 more cycles of chemotherapy. Okay, so the answer is going to be chemo followed by debulking surgery, right? Chemo with debulking surgery. Okay, somebody is saying the last option was staging laparotomy, right? Now, staging laparotomy is a general term we use for surgery for ovarian cancer, but typically if it is advanced stage cancer, we call it as a debulking surgery, not really a staging laparotomy, right? So debulking surgery is a term that we specifically use for stage 3 and 4 cancers. So we will give neoadjuvant chemotherapy followed by surgery. नहीं, रेडियोथेरेपी अगर ऑप्शन में था तो वो आंसर वैसे भी नहीं है. ओके, मोस्ट ऑफ द ओवेरियन ट्यूमर्स आर नॉट रेडियो सेंसिटिव, सो वी डोंट यूज रेडियोथेरेपी. सो कीमोथेरेपी अलोन, रेडियोथेरेपी अलोन, दीज आर नॉट द आंसर्स फॉर ओवेरियन कैंसर. ओके, सो इट इज always generally we go for a primary surgery followed by adjuvant chemo. But if the patient is either inoperable, right, or if the patient cannot be cytoreduced, then we can give neoadjuvant chemo, especially if the patient has ascites peritoneal metastasis. Okay, so that's the best answer here. Okay, so again, I'm not very sure of the language of this question, but this is the best possible recall I can get, that if we ligate artery for PPH, then which will serve the uterus with anastomosis? Okay, so the best answer here is going to be ovarian artery. Remember, the ovarian artery dilates 3 times in pregnancy. Okay, although most of the blood flow comes from the uterine artery, but a significant amount can come from the anastomosis with ovarian artery as well. So best answer remains as ovarian. Arcuate artery, round ligament artery, they're actually branches or of the uterine artery itself. So this is the best wordings that I have got so far. If you have a question, then you can let me know, but I think the best answer would remain as ovarian artery. Okay. Okay, so Muskan is saying ovarian branch of uterine. Yes, so that will anastomose with the ovarian artery, right? So ovarian branch of uterine artery anastomoses with the branches from the ovarian artery, and through this anastomosis they provide the blood flow. Okay. All right. Chalo, let's look at the next question. So this is again a psychiatry and OBGY mixed question. They have been asking a lot about these psychiatric drugs. Okay, so patient comes with bipolar disorder. She is already in the 3rd trimester and she is taking daily 750 milligrams of lithium. Now she is well controlled. What will you advise her? So I know a lot of people are telling you to decrease the dose. That is an incorrect answer. Okay, the answer is increase the dose, and I'm very sure of it. Okay, so what happens is that the lithium excretion increases a lot as pregnancy advances. Okay, so the serum lithium levels are going to drop, and that is why we need to keep a check on serum lithium levels, and we need to do it every 2 weeks until 36 weeks, and then every week after 36 weeks, right? So the answer has to be increase the dose and not decrease the dose. Even though the question said that the patient is well controlled, it doesn't mean that you are going to reduce the dose. Okay, the answer is actually increase the dose. All right, and I've had a word with Dr. Sachin as well, so even the psychiatry books say the same. So the answer is increase dose. Okay. Yes, I would definitely say the paper wasn't easy. In fact, I would say it is an unexpected paper. Don't worry, it is the same for everyone, right? So I won't say that it is very difficult, but yes, a little unexpected from what they ask. And actually, yes, there is no the PYQs were very, very less. PYTs are there, but that again, you know, you need to be thorough in that topic. If you're only superficial in PYTs, then that won't really help. Okay. I'll come back to some top questions which people have come later in the live chat. So I'll repeat the first 4 or 5 questions again. Don't worry. So which infection is not teratogenic? ठीक है, so ठीक है, varicella की जगह चिकन पॉक्स था, कोई बात नहीं, right? So the answer is herpes. Herpes is not teratogenic. Yes, if a woman has active lesions at the time of delivery, okay, genital herpes, then it is a contraindication for vaginal delivery when the preferred route is CS. So that is because of transmission to the baby perinatally, but it doesn't really cause teratogenic effect on the baby, right? So the answer is going to be herpes here. Yes, so somebody said there was an option of oxytocin in inversion. मैंने पहले भी बोला बेटा, inversion में मैं specially पढ़ाती हूँ, oxytocin नहीं शुरू करना है. You have to first begin repositioning. Only when you have majorly done the repositioning, only then you start oxytocin. और सबसे last में placenta remove करते हैं. Okay? Right, so those were the 17 questions I have. If you think there is any other question, let me know. I'll quickly cover the first 4 or 5 questions again because people came late in the live chat. So this was the first question that I did. Recombinant HPV vaccine has which antigen? I'm not sure why you got confused, but yeah, people who are in my Telegram group, I have been revising MCQs over quite some time now. Yes, and this is something that we also did very recently. So the recombinant vaccines are made from L1 capsid protein. We did it in DVT also, PYT also, everywhere we've done. Not E6, E7, bache. E6, E7 is for malignant transformation. Okay. Then the second question was a virilizing ovarian tumor, and the answer is arhenoblastoma. Okay, arhenoblastoma. Okay, so thecoma से confusion हुआ है बच्चों को. बेटा thecoma is primarily a estrogen producing tumor. Okay, it is primarily a estrogen producing tumor. Then this was the third question that I discussed. What is the reason for increased blood volume at term in pregnancy? I think it is written there as what? I think there was a graph also that they have given probably in this question, but I don't really think you needed a graph to answer this question, right? So increased fluid retention along with estrogen and aldosterone. So estrogen is the reason why there is upregulation of RAS. And because of the upregulation of RAS, there is release of aldosterone and there is salt and water retention by the kidneys, right? So that is going to be the answer. Then, yes, this was the question that I discussed and some of you were asking in the chat box. So management of uterine inversion with the placenta still attached to it. So reposition the uterus without removing the placenta, okay? Then, fifth question was, maybe some of you had missed. So this was woman 3 centimeters dilated, 70% effaced. Probably the station of head was also given here as -3. Okay. And on PV examination, a bag of worms is felt, which is what is the cord, umbilical cord in the bag of membranes. So it is a cord presentation. Again, in this question, probably they had given the fetal heart rate also as per the recall and it was normal. Okay. So the fetal heart rate was normal. Despite the fact that the fetal heart rate is normal, your answer will still be emergency cesarean because you know the moment the membranes are going to rupture, it will be a frank cord prolapse. Abhi it is a cord presentation, right? So that is why it has to be an emergency cesarean because you don't want to do a vaginal delivery. So we are not going to start oxytocin in her, right? So those were the initial 5 questions which I think people had joined late. If you feel there is some other question, but I think these were the questions that were there. A couple of them are integrated with path, forensic and psychiatry. That's what they have done. So you may consider them as other subjects, but yes. No. You never put cord above the vertex, bate. वो तो वैसे भी कभी नहीं करते. Scene Kajla. We never put the cord above the vertex. This is not even done in cord prolapse. In cord prolapse, all you can do is gently put the cord inside vagina. You never put it above the vertex or put it inside the uterus. So that option is any which way is wrong. Okay. The options are always going to be tricky. So the idea is when you get confused between the two options, look out for keywords and that is what is going to help you solve the questions. What I would say is whatever the paper was, it is same for everyone. So you need to learn from what has come in the exams. You need to understand that superficial knowledge about important topics does not help. Only doing PYQs does not help. So you need to go to the core and you need to go to the concepts and application of concepts. Also, every exam is a learning experience for the upcoming exam. So, कोई बात नहीं, ये जो भी था, it was same for everyone. Let's wait and watch. I'm sure everyone will do mistakes. Even toppers do mistakes. So, don't let your morale go down. Let's wait and let's prepare for what is coming next. That is very, very essential. We have to take every exam as an opportunity. ठीक है? So, आपको इसको भूलना पड़ेगा. Learn from it. What has been asked, how it has been asked, but then you have to move forward. है ना? Till then, I'm just going to hope that you all do well, right? But believe me, every exam should be a learning experience and it should make us look forward for the next one, because that is going to be the next opportunity that we are going to have. Okay? So please don't trouble yourself a lot. I know after exam you do feel a little demotivated looking at the recalls, right? But the purpose is not to make you feel demotivated. The purpose is to make you realize how to approach certain topics, where to go into more depth, what to expect, right? So that is the purpose. The purpose is not to demotivate any of the bachas, right? And you should not be demotivated. जो भी था वो सबके लिए था, है ना? So कोई बात नहीं, whatever it is, let's see what best comes out of it and let's see what best we can do next, right? And just to tell you that tomorrow we are going to start with a free test series on the app under the daily quiz section. Tomorrow we are going to upload 20 MCQs both for NEETPG and FMG because they are our next targets. It is free for all. So if you open the app and go to the home page, you'll go to the scroll down to the daily quiz section. Okay. The schedule of the free mini test series has already been uploaded. We'll reshare it. So start getting back into the rhythm, right? We are going to give 20 MCQs every day. The subjects have been already mentioned and we are finishing one round of this mini test series until DVT, which starts on 12th. Okay? It starts on 12th. And then we will have another series after DVT, right? So please understand, we are going to hammer concepts, help you in revision with DVT. DVT is going to be really special. We are ensuring we give you the right material, which is not less, which is not more for your last 3 months, because we still have 3 months for the exam. So the DVT book itself is something that you can rely on completely for your upcoming NEETPG exams. For our FMG bachas, we are starting with DFX, and both these revision series had an excellent hit rate in the last year exam, right? So let's look forward for what is coming up. Let's take it as an opportunity. Let's get back on track. Okay? Till then, all the best. Hoping to see you on the other side when the results are out. Hoping to share the hot seat with all of you. And God bless you all and take care. And सीखेंगे, आगे बढ़ेंगे और घबराएंगे नहीं. ठीक है?